Hi, so today we will be talking about spinal cord injury and spinal shock. Spinal cord injury, what is it? It is an injury to the spinal cord that results in temporary or permanent changes in the spinal cord's normal motor, sensory, or autonomic function. It can involve contusion, laceration, or compression of the cord. It can be characterized as complete or incomplete. It is likely to have a lasting and significant impact on most aspects of daily life. In a complete spinal cord injury, there is no function or sensation below the level of the injury. This is usually irreversible. In an incomplete spinal cord injury, it indicates that some messages are getting through. It is unique to the person, so therefore no two incomplete spinal cord injuries are exactly the same. Now, let's talk a little bit about the spinal cord. In order to understand spinal cord injury, you have to know a little bit about the spinal cord. So, along with the brain, the spinal cord makes up the body's central nervous system. It is the largest nerve and is the pathway for messages traveling between the brain and the rest of the body. It consists of gray matter, which is made up of neurons, support cells called glia, and blood vessels, and white matter, which is made up of myelin-coated axons. It is protected by the meninges, which are the pia mater, the arachnoid, and the dura mater, cerebral spinal fluid, and adipose tissue. The spinal cord is divided into four sections: cervical, C1 to C7, thoracic, T1 to T12, lumbar, L1 to L5, and sacral, S1 to S5. In the sacral section, the five bones are fused together into one bone. Some functions of the spinal cord include controlling body movement, regulating visceral functions such as cardiac reflexes and reflexes that control the bladder. It transports sensory signals from the body to the brain and motor signs from the brain to the body. It provides neuron and synapse networks to produce involuntary responses to sensory stimulation. So now, knowing a little bit about the spinal cord, we can better understand why an injury to the spinal cord can have a lasting significant impact on most aspects of daily life. Now we can get back to spinal cord injury. Some causes of spinal cord injury include motor vehicle accident, falls, especially in the elderly, sporting accidents like football, industrial accidents, gunshots, stab wounds, and diving head first into shallow water. Some risk factors: male gender, age 16 to 30, engaging in risky behavior, such as diving into shallow pools, and driving a car or an ATV at a high rate of speed. Race and ethnicity: 63.5% non-Hispanic white, 22% non-Hispanic black, 11% Hispanic, 2% Asian, and 1% Native American. Being elderly, older than 65, or having a bone or joint disorder such as degeneration. Some complications include orthostatic hypotension, spinal shock, which we will talk a little bit about more later in the presentation. It affects approximately half of individuals with spinal cord injury. Neurogenic shock, autonomic dysreflexia, which is an abrupt onset of excessively high blood pressure that is triggered by an irritation, pain, or other stimulus below the level of the injury. It usually occurs in patients who have injuries above T5. Atelectasis, related to inability to draw in enough air into the lungs. Pneumonia, related to inability to clear secretions and use of mechanical ventilation. More than 25% of all deaths associated with spinal cord injury are related to ventilator-assisted pneumonia. Loss of bowel and bladder control, respiratory difficulties, tetraplegia and paraplegia. Tetraplegia, formerly known as quadriplegia, is paralysis that affects the cervical spinal cord or the first thoracic vertebrae, and it affects both the upper and lower extremities. Paraplegia is paralysis that affects the body from the chest or waist down, typically T1 to L5 regions of the spinal cord. Seizures, DVTs, and sexual dysfunction. Sexual dysfunction can occur in men and women. Men may experience inability to get an erection or to ejaculate, and women may experience changes in lubrication and the ability to reach an orgasm. Manifestations of spinal cord injury can include, but are not limited to, numbness and tingling in the extremities, headache, pain, pressure, and stiffness in the back or neck, inability to move the arms and legs, problems with ambulation, loss of bowel and bladder control, and muscle spasms. Some diagnostics and lab tests include X-rays to visualize vertebral fractures, myelograms to view damage to the spinal cord and surrounding tissues by injecting contrast dye, CT scans and MRIs. These will provide information about the type and level where the spinal trauma occurred to detect abnormalities to soft tissue and to visualize small fractures that may not have been seen by X-ray. Somatosensory evoked potentials, which can be used to detect neural response to physiologic, electrical, or magnetic stimulation. Lab tests, CBC, to closely monitor H&H to detect blood loss, and ABGs to evaluate oxygenation and ventilation. Some treatment, pharmacologic, methylprednisolone, given in high doses within 8 hours of the injury to improve neurologic recovery, dexamethasone, anticoagulants such as heparin or Coumadin, given after 24 hours of the injury for DVT and pulmonary embolism prophylaxis, opioids and NSAIDs for pain control, antibiotics if needed, antispasmodics such as baclofen, cholinergics such as bethanechol to decrease spasticity of the bladder, allowing for easier bladder training. Non-pharmacologic, immobilization devices and traction, halo traction and skull tongs to provide immobilization and traction for cervical injuries. You want to monitor for infection at the insertion sites. And for halo, you want to make sure the wrench is with the vest in case CPR is needed. Body casting and bed rest. These are usually used for thoracic, lumbar, and sacral injuries to promote healing. Some cervical intervention includes decompressive laminectomy and spinal fusion. Nursing care. You want to assess the respiratory pattern. You want to maintain a patent airway. Mechanical ventilation may be necessary depending on the level of the injury. You want to immobilize to promote healing and prevent further injury. You want to monitor ABGs to assess oxygenation and ventilation in the effort of preventing respiratory arrest. You want to encourage deep breathing and use of incentive spirometer to help prevent atelectasis and pneumonia. You want to monitor for signs of infection. Assess for hemorrhage around the fracture site. Assess for signs of shock, such as hypotension, tachycardia, and weak thready pulses. Frequent vital signs. Assess neurological status. Assess motor and sensory status. Monitor for signs of autonomic dysreflexia, such as elevated blood pressure and facial flushing. You want to provide patient and family education, provide emotional support, provide community resources, and refer to urology for the sexual dysfunction concern and issues with bladder incontinence. Some nursing diagnoses that goes along with spinal cord injury are risk for aspiration, ineffective breathing pattern, impaired physical mobility, bowel incontinence, impaired urinary elimination, urinary retention, acute pain, self-care deficit, depression, anticipatory grieving, and disturbed sensory perception. Statistics. Approximately 17,730 new spinal cord injuries occur each year in the United States. 78% of them are males. Approximately 249,000 to 363,000 are living with spinal cord injury in the United States. Average age at time of injury is 43 years old. Some causes: vehicular, 39.3%, falls, 31.8%, violence, 13.5%, sports, 8%, medical surgical, 4.3%, and other things such as joint degeneration, 3.1%. Now, let's talk a little bit about spinal shock. What is it? The spinal cord's response to the inflammation caused by the spinal cord injury. It usually occurs immediately after injury and can last from several hours to several weeks. It is a complete but temporary loss of motor, sensory, reflex, and autonomic function. It is characterized by spinal cord swelling, decreased blood flow, decreased blood pressure, and complete loss of motor function, spinal reflexes, and autonomic function below the level of the injury. Some manifestations of spinal shock include flaccid paralysis, paralytic ileus, altered body temperature. A lot of the time, body temperature is according to the environment. So if the environment is cold, patient's temperature may be low. If the environment is warm, the patient's temperature could be elevated. Diaphoresis, bradycardia, altered sensory response, irregularities in the musculoskeletal system, depressed genital reflexes, urinary bladder and GI tract overflow and incontinence, and pale dry skin. Causes. So the main cause of spinal shock is a severed or extremely swollen spinal cord. Now, stages of spinal shock. There are 4 of them. So starting with stage 1, which occurs 1 to 2 days following the injury, nerve cells become less responsive to sensory input, resulting in full or partial loss of spinal cord reflexes, also known as hyporeflexia. Stage 2, occurring 1 to 3 days following the injury, initial return of same reflexes, polysynaptic reflexes, which are those that require a signal to travel from sensory neuron to a motor neuron. Stage 3, occurring 1 to 3 weeks following the injury. Hyperreflexia occurs as a result of new synapse growth. It's normally temporary. And stage 4, occurring 1 to 12 months following the injury. Hyperreflexia continues and spasticity may develop. This stage takes longer than other stages. Some treatment for spinal shock. So treatment for spinal shock tends to focus on treating the spinal cord injury as a whole. Physical therapy, occupational therapy, analgesics, antidepressants, and assisted respiration. Some nursing care. Monitor for hypotension and bradycardia. Monitor for reflex activity. Assess bowel sounds to monitor for this paralytic ileus. Monitor for bowel and urinary retention. Monitor for return of reflexes, and provide emotional support and education. Health promotion and disease prevention. Wear your seatbelt. Don't speed. Don't drive while under the influence of drugs or alcohol. Change position slowly if you're on those antihypertensives or diuretics. Wear non-slip footwear. No diving or dive feet first. Wear safety equipment during sporting activities and performing hazardous work tasks. Interdisciplinary team. So your interdisciplinary team or your collaboration are the caregivers that are incorporated in your care during this process. So they overlap practice, which with shared goals coordinated into a unified management plan, allowing for group decision making and group responsibility with the patient considered an active member of the team. Each team member builds on each other's expertise to achieve the common shared goals. Patient progress is usually communicated through written documentation. So with that being said, the interdisciplinary team consists of patient and family or caregiver, primary care physician, neurologist or neurosurgeon, spinal surgeon or orthopedist, ICU nurses, dietitian, respiratory therapist, occupational therapist, speech and language therapists, physical therapists, social workers, clinical psychologists, and urologists, physiotherapists, and radiologists. So, a summary of it all. So us as nurses, we want to focus on the patient, and our overall goal is to return the patient to as close to maximal physical health as possible, preventing complications resulting from the injury and the ones related to the disability. Thank you all for allowing me to share my presentation with you today. Have a great day.